Good evening. My name is Lisa Cawthorne, and I'm here as your host for Focusing on You, which is an educational series sponsored by Hope Abounds. Hope Abounds is an organization that provides education, advocacy, and hope for cancer patients and their families. We focus on women and children who have a cancer diagnosis. Last week, we interviewed Tammy Kimball, who is a previver who does have a genetic marker for breast cancer. And this week we will continue our series by talking about family history and genetics. So today we have two ladies from the Central North Carolina Triangle area, and we're going to talk to them sort of about their area of expertise and their personal history a little bit. So I do want to welcome Kim Wellons, who is our director for the Central area for Hope Abounds and the Raleigh-Durham, Cary, Apex, and it keeps growing as far as more than that. And you are a breast cancer survivor yourself, so we'll look forward to hearing your story. And they also want to introduce Nira Johnson, and we're thrilled to have your expertise here as a genetics counselor. And you're also from the Triangle area, correct?
Yes, I am.
So first of all, we're going to start with you, Kim, and can you tell us a little bit about your background, your cancer experience, family history, your genetic testing experience?
Sure. First, I'd like to say that I am the Central Region Director for Hope Abounds, and we encompass some of rural North Carolina on the I-95 corridor, all the way in Greensboro towards Charlotte. So that is my area.
It's a big area.
A big area. And we are growing slowly, and we're welcoming support to the program because we offer so much for cancer survivors, cancer families, and patients who are in active treatment. I'll share my story with the group in the fact that I was 57 years old, thought I was healthy as I could be, running 5 or 6 miles a day, every day, and through a self-exam, found a lump, went to my doctor, and that waiting period of what's wrong, let's do an ultrasound, let's look at things, to the biopsy was a little scary. And of course I got the phone call that said it is cancer. And those are the words that no one wants to hear. Couldn't believe it was me. I thought I was completely healthy. Proceeded from there to find out that I had HER2 breast cancer, estrogen positive, made a choice of a bilateral mastectomy, went through the full treatment spectrum, was lucky in the fact that I was never sick. I was able to do my chemotherapy and come home and get on my treadmill every day and live my life pretty fully through the whole experience. However, I do want to say it's very important to advocate for yourself. I had great treatment where I was, but I was assigned an oncologist, and that did not work with my personality. So because I was bold enough to advocate for myself, I was able to change oncologists with the same practice. It just was not someone that met my needs. An oncologist that it assured me that I could continue my activities as normal. Through the experience, I became a grandmother for the first time. I had a child get married in the midst of it, but really did well. And I attribute that to exercise and a great attitude, great support. But for those that cannot advocate, I suggest that you write your questions down when you go to your doctor. My oncologist would laugh every time I'd go in and say, "Are you through with your questions yet, Kim? Do you have any more today?" And so it was just, it could have been a horrible experience, but I have to say I was healthy and did well with a positive attitude and was able to continue my my daily activities for the most part. I pushed for genetics testing to begin with, and my doctor didn't really think at that point I was postmenopausal. Just didn't think that I needed the genetics testing. However, I kept pushing because I wanted to know for my girls. I wanted to know that they were going to be okay, that this wasn't something that we needed to pay close attention to for them. So I continued to push. My father was a lung cancer. He died of lung cancer, but he also had melanoma. I had an aunt that had lymphoma. I had a first cousin that had breast cancer. And still that wasn't quite enough until one of my sisters was diagnosed also with breast cancer just as I was. So finally I pushed and pushed, and I was tested. Luckily, everything was negative. So it kind of took a little burden off our girls. They are monitored. They've shared with their doctor, so they will be monitored closely as they proceed in life and make decisions for themselves. But overall, I think women and patients need to ask those questions. The doctors had done a very in-depth family history on me when I was diagnosed. So I just think it's very important that you keep pushing. If there are questions or doubts, those are things you need to do for yourself and for your family.
So what I take out of what you just said, a couple of things really pop out. Number one, through your treatment, you tried to stay very active. I think that's important for all of us to hear. They've done research now proving that people do better when they're in treatment when they try to stay as active as possible. Those sort of thinking of just laying in bed the whole time, that's all changed, and you're sort of living proof of that as a case study, but they have done research to show that that really helps people with fatigue, with anxiety. The other thing I find is you said your girls, which they're adults now, but you said they shared with their doctor the family history. And then the other thing is you said you advocated for yourself because you were concerned about your family. And those are three great takeaways that I like for people to hear. And you're a real life person sitting here surviving and telling other folks about that.
And I can't say enough about, I know that when you come home from treatment, you may not feel great and you may be a little tired, but honestly, if you can pick yourself up to even do a mild, moderate walk, it does a lot, not only for your physical health, it does so much for your emotional and mental health. I was blessed with friends that came by every day or two, or if they knew I had treatment, they were calling to make sure I was okay. Hey, Kim, you want to go to lunch today or tomorrow? No, you don't feel like it today. But I actually came home from treatment and was able to get on my treadmill. But that is who I am, and I believe in physical exercise, and I believe in taking care of the entire person, the emotions, the mental part as well. So, and then as for my girls, they're the most important thing to me, so I wanted to make sure I advocated so that they would be taken care of and know what was going on in their bodies.
Nice. Well, and that sort of brings us to you, Nira. You're here as our expert to talk about family history, genetics, counseling. So maybe let's start out with telling everyone what a genetics counselor does, because not everyone knows what that position even is.
Yes, I have a lot of people asking me what a genetic counselor does. What is it? I've never heard about this position, this role, this career. So a genetic counselor, there's many different definitions that a genetic counselor has. One main definition that a genetic counselor has, especially in the clinical world, that traditional sense of genetic counselor, is educating patients about their family history, their risks, and then sort of facilitating that decision making in terms of options for testing, if that's even appropriate for them, not just medically, but also personally, and sort of personalizing that experience of understanding what your background is, your family history, any medical history that's there that could affect not only you, but the rest of the family. What kind of testing is available for you? Is it available for you? And if so, what are you going to do when you get the results? Those kind of next step approach, it's the planning. The overall goal and the way I look at genetic counselors is we empower patients to advocate for themselves. There's so much in not only genetics, in the medical world in general, that, if you're not in the medical world, if you're not in it, breathing it every day, there's no reason why you should know that stuff. Even our most tenured providers, our medical world, don't necessarily know everything, which is why it's so important for patients to take their steps, to take their actions of learning for themselves, their background, their family history, and what's available for them so they can take those steps. That's our job, is facilitate that decision making by educating those patients.
Excellent. So some people may have heard of it with prenatal testing. Sometimes they associate that with genetics. But in your case, you're dealing with sort of the cancer world. And can you go into that a little bit so people will understand? Because first of all, there's 100 different types of cancer. Even among breast cancer, there's so many different types, and a little bit of this and a little bit of that, and all determines different treatment plans. But how do genetics, and specifically family history and maybe genetic markers, affect a cancer diagnosis?
Very good. So kind of starting from the beginning, most people, when you talk about genetic counselors, you talk about genetics, that world, they do refer to, it's like the pregnancy planning and those kinds of things, people wanting to kind of see what their kids might be at risk for. Yes, you're right, and that's what most people are aware of and what most people are familiar. We use that to kind of help define what we do.
Okay.
In the cancer world, and there's many different kind of departments and worlds that we can plug into. In the cancer world, it does in fact have to do with what kind of family history is there, what types of cancers are we seeing there. If we talk about cancer as a whole, there's, the way I explain this to patients is that there's 3 main groups of cancers that we refer to, amongst others, of course, that we refer to try to sort of place patients in that sort of risk bucket. What most people refer to when we talk about cancer is what we call in the medical world the sporadic world of cancer. Those are the cancer just happens by chance. It's the aging condition. So most individuals who have cancer, most individuals who know somebody with cancer, those individuals probably fall under that category of the sporadic world of cancer. That's where about 87% of all cancers fall under.
It's a big percentage.
Exactly. So most cancer out there is not in the hereditary world that we know of. The second group of cancers is the familial groups of cancers. That's sort of that gray zone. So you have a family history. It might be cancers that may link to one another, might see a specific pattern, might not, but the family history is there. So as I say to my patients, at least for the cancers we see in the family, your risk is elevated. How elevated it is, we don't know, right? We don't know what causes it. We didn't look at DNA. There's familial aspects of things. There's environmental stuff. There's a lot of things that could take into account with that. And then the third group of those cancers is the group of hereditary world of cancer. And that's where the highest risk for cancer is. That hereditary group of cancer, that's where 5 to 10% of all cancer fall under. And so those are the cancers where there's a genetic predisposition that was identified in the DNA. So we looked at the DNA to find a genetic change that can explain that family history, that specific cancer, or at least some of that family history. Whereas in the familial world is that unexplained family history. So either I looked and didn't find anything, or I didn't look at all. So it's that I don't know.
Maybe in Kim's case, talking about melanoma and lung in her family, another sister with breast. Should be concerned. There's something going on in the family, but the genetic testing ended up being negative.
Exactly. Okay. So there's a lot of different things. So I always talk about the only way to differentiate between the familiar world of cancer and the hereditary world of cancer is to look at your DNA. It's the only way to do that. Now, if the DNA test comes back negative, that's great. We've reduced the risk dramatically. You don't seem to be at that sort of hereditary group of that 90, sometimes depending on the gene, 100% risk for cancer. But we still have that unexplained family history because we haven't looked at every single individual in the family, and not everybody has done testing. So that unexplained family history is still there. So that's where we place patients like Kim in that sort of high risk negative, right? So we talk about genetic testing being so important because the only way to find out how high a risk is to look at the DNA. But the fact that you're negative and it's amazing, it's great, we really did reduce your risk, there still might be some things there that we can do to reduce risk that you still might have because we haven't explained the family history yet. Risk models, those kinds of things, screening, those kinds of things. So that's kind of where we go with that.
Okay. And then risk in general, when you talk about somebody having a genetic mutation marker that makes them at risk for cancer, it doesn't always equal they're going to get cancer.
Right.
But what that means is they're going to have a higher risk for getting cancer. So can you explain that a little?
Yes. So that's a very important point that I try very hard to explain that to the patients because patients don't necessarily understand or know that. So all cancers is genetics. It's caused by a genetic change within a cell that then turns into uncontrolled division. Cancer happens from there. The goal is to look at that DNA and kind of figure out where that mutation or change come from. All these genes that we talk about, genes that we test, we all have those genes. Everybody has them. It's that sequence of that gene, it's the function of that gene that matters. And it's whether or not we were born with that specific mutation or over time we've kind of gained that mutation, in our life, because we all do that. When cells divide, DNA has to replicate itself. So the difference in the hereditary world of cancer and the sporadic world of cancer is that specific mutation. And so when you inherit cancer, cancer syndrome, when you inherit a predisposition to cancer, what you're inheriting is a genetic change that puts you at a higher risk of developing cancer. Okay? Doesn't mean you're inheriting cancer. There's so many patients out there who are positive for a specific genetic predisposition, a specific change that puts them at that higher risk, but never ever develop cancer. Now, is that because we have screening? Is that because we do know so much about these types of mutations that we can screen for it? Probably. It also has to do with, as you mentioned before, how healthy we are, our lifestyles, those kinds of things, environmental things that we can't necessarily control, right? So there's a lot of different things that we that take into account with that. So the sporadic world is one of those things that I just call bad luck, right? The likelihood of you having bad luck, once is low, twice is even lower. With a genetic predisposition, it's much higher. Okay. So again, the idea is that that's kind of the goal of testing, right? Is to figure out, do you have a risk for developing cancer? Most cancer out there, as I said, is one of those sporadic types of cancer that you can't necessarily anticipate. But there's that small group of cancers that we call the hereditary world of cancer, the hereditary types of cancer that we can identify, that we can find, that we know so much about, that we can prevent. And our goal, and most of my patients that I see are actually individuals who've never had cancer, but have a family history that's so significant, putting them at increased risk, that in order for us to understand that risk, the only way is to look at their DNA. And the goal with that is to figure out if there's a risk. One, what are you at risk for, right? Are you at risk just for that family history of cancer, which is what we're seeing with Kim's family history and testing, is that there is a negative genetic test for her, right, for Kim, that there's no hereditary forms of cancer, but we're still at that risk for the family history cancers, right? Things we don't see in the family history, we're probably not at risk for, right? Whereas in the other types of cancer, when we're seeing a predisposition, we know that even things that do not pop up in the family, you might still have a risk for.
So what are some of the cancers that we know there's an associated risk as far as the familial history or the genetic mutation that's inherited? What are some, I mean, we hear about Angelina Jolie did a wonderful job at publicity. So everybody knew about breast and ovarian through her, which is great, and oftentimes we say we need someone famous to get this kind of cancer, so there's more awareness. So could you address some of the cancers that you would say are at higher risk for having a familial genetic mutation?
Absolutely. So you're right. I mean, a lot of the things that we hear, a lot of, people hear about cancer's risks and what we're looking for from publicity, right? Those are the people we look up to, right? We want to be them. We want to see what's there and kind of follow that role model, right? So Angelina Jolie did a great job. You're right. So we know about the breast cancer, the ovarian cancer, that kind of family, prostate cancer, pancreatic cancer, those kinds of things that are there. There's so many, it's hard to kind of answer that question because there's so many different cancers we know have a genetic link or hereditary link, but there's no criteria, right? So there's a lot of different things that we look at. The main focus in the hereditary world of cancer, at least in my world of cancer, in the clinical world, are the breast and ovarian cancer are huge.
Okay.
Breast and ovarian is big. We have melanoma. Most people think melanoma is environmental, and most melanoma is environmental. So that's a big thing. Melanoma in the family may not be directly in criteria, but it does link with many different syndromes we can test for. There's prostate cancer. Again, people don't think men can have those cancers, their hereditary predisposition, because they think the Angelina Jolie effect of breast, ovarian. Men don't get ovarian cancer, of course. Men don't get breast cancer. Well, they do. They have a risk for breast cancer. Prostate cancer is huge. So ovarian cancer for women, prostate cancer for men, right? Women don't have prostates. Pancreatic cancer for both. So the melanoma, all that stuff. So those are the four cancers. So breast, ovarian, melanoma, prostate, 5. Pancreatic. The other cancers that people don't think about are the colon and uterine cancer. Those are big ones. And then stomach cancer. So those are big things when it comes to criteria. So when I talk about criteria, I mean things that are going to allow a patient to get testing and it will be covered, basically.
Okay.
So medical guidelines set out criteria to say a patient has a family history that's significant enough that in order to understand the risk, we have to look at DNA.
So when you talk about going back to Kim and the advocacy and telling your physician about family history, if you're going to, well, first of all, sometimes it's challenging to get your own family history. So what would you recommend to folks about trying to find out their family history and how to talk to their doctor? What would you say to them?
It's funny because I joke with my patient about, that's a great Thanksgiving dinner conversation, right? It's like, let's talk about who had cancer, right? So
Not
we
so
joke
much.
about, right? Exactly. So we all talk about, how joking that some people say, everybody gets together at Thanksgiving, but nobody really wants to talk about cancer.
Right.
So one thing, a resource that I at least provide to some of my patients is a family history questionnaire. And that's, you can find it in many different places. One of which I believe is on the Hope Abounds website. So questionnaires, questions to ask are things like, the important pieces are those types of cancers, number one. So do we have breast, ovarian, colon cancer, pancreatic cancer, melanoma, or honestly, any type of cancer? I always encourage patients to say, don't think about specific types of cancers. Just ask about anything.
Right.
Even leukemia, brain cancer, those things that we know may not be in guidelines criteria are still associated with those other types of cancers. So having that family history might strengthen the need or the medical indication to do genetic testing. So gather information about any type of cancer you have in the family. Go to that person, the matriarch in the family, or the person who knows the best about the family, or you think so, to gather that information. So number one is the types of cancers in the family, and that means any type of cancer. So that's number one. Number two, the ages of diagnosis. Now, it doesn't have to be the difference
In their
between 42
20s and their 30s.
Yeah.
And
so a decade is fine. So that's a good one. If you can get an exact age, even better, but a decade is fine. The other piece is how many. One side of the family is the key. So who had the type of cancer, what age, and what type of cancer is it? Right?
And both sides of the family,
Both
not
sides
just
of
the
family.
mother's side.
Exactly. Men and
father's
women
side
with
too.
these. So the most important thing to understand about this is that these genetic predispositions, they're not gender biased. Men and women can carry them just alike. The difference is how high the risk is with that genetic predisposition, but they each can carry those mutations and therefore pass them on.
Okay.
For the next generation.
And is it I'm getting ahead of myself,
That's
but
okay.
can they, is it a guarantee they're going to pass it on to their
question.
children, or
No. So
Okay.
we always say if we know that there's somebody in the family that has a genetic predisposition, any first degree relative of theirs is at 50%. So
Okay.
50% of inheriting. So first degree relative, and when we talk about family history, we go first, second, and third degree relatives. First degree relatives are children, siblings, and parents.
Okay.
Those are first degree relatives. So they're the most influential for your own risk. The next piece is second degree relatives. So those are the sort of the one off of that. So aunts, uncles, grandparents, nieces, nephews. Those are the kinds of people who are the second degree. And then the third degree relatives are your first cousins. So your aunts and uncles, their kids. And then anything with one great in front of it. So a great grandparent or a great aunt or uncle. Those are the sort of people that we're looking for in terms of cancer.
So that sort of goes back to the importance of a good family history, because even though maybe your father or your mother didn't have cancer, they could carry a genetic mutation that was passed along from their parents. So it may not be that your mother or father had cancer, but it could be in the extended family. Is that right? Okay.
Which is why we go as far, because going back to that whole idea of you have a genetic predisposition does not mean you're going to get cancer. It just means that you have a higher risk we need to
Higher
watch
risk,
for.
right.
Right. And that's the goal, is identifying, are you at risk? If I don't look and I don't find that you're at risk, I can't do anything about it. Right.
Okay.
And so the idea is if we find, we can monitor for it. So it doesn't mean you're going to get cancer. It just means that you're at risk. Knowing that there are individuals in the family who are at a higher risk can dictate, one, what we do for them, and therefore what we do for the family members.
So it sounds like a very proactive way of taking control of your health and your wellness.
Exactly.
And your follow-ups with your doctors, and perhaps testing that could be done.
Absolutely.
So let's focus a little bit on the test itself. Is it, what do they do for a genetic test?
So, so in terms of samples, or in terms of how the test is done, is that what you're asking?
A little bit of everything.
All
Like,
right.
is it a blood sample? Do they take your hair, like on one
If
of those
only.
TV shows, or
If only. So there's different ways to do it. It used to be just a blood.
Okay.
We took a vial of blood, and that's kind of how we isolated DNA and kind of looked at that. Different technologies apply. So nowadays, and technology evolves every day. So when over the years, we've kind of now have a second piece, which is saliva. So in my office, we mainly do saliva. So it's a little tube that a patient spits in, and they have to have 30 minutes before, at least 30 minutes with nothing in their mouth, no water, no gum, no food, no anything.
Okay.
So the idea is to get clean, slate. Everything is from your basically cheek cells is what we're getting. And so spitting a little bit, it's funny because every time a patient looks at this tube, it's like, oh my God, I'm supposed to get that much spit? No, it's a little bit of spit in there. You get that in, and there's media that we close, and it kind of gets shipped to the laboratory
And
we use.
the cheek cells are going to show the same or not genetic mutation as any
Very
other
good.
cell in your body.
Yeah, so every
Okay.
cell in your body has exactly the same DNA for the most
Okay.
part. So it doesn't matter what cell you look at, it's
Okay.
going to be the same DNA that we're looking at for testing. Yeah.
And then how long does that test take, and what do they test for?
Yeah. So we in our facility we use Myriad Genetics as a laboratory. And the test we use is called MyRisk, and it tests for 28 different genes. So the way it works is we get a sample, we shut it down, shut it with the media, everything, all the information goes, sends it to Myriad. Myriad isolates the DNA and then tests for the 28 different genes to
So
chip.
28 different genes.
Yep.
So
So-
what are those 28 genes? What are they looking for?
Yep. So 5 to 10 years ago, we were really looking at specific syndromes. So
Okay.
we were looking at, so a family history like Kim's would basically meet criteria for things like the BRCA1 and BRCA2. So
Okay.
the hereditary breast and ovarian cancer syndrome. That's what we call met criteria for. So we would really just look at that type of predisposition that she was at risk for. Nowadays, or if family histories have colon cancer, uterine cancer, those kinds of things, then we would look for, things like Lynch syndrome. These are 5 different genes that are associated with that sort of gastrointestinal types of cancers and brain cancer and those kinds of things. In fact, ovarian cancer overlaps the 2 syndromes. So that's the other thing that people don't realize, that some cancers may mean that you might be at risk for more than one kind of syndrome, which is kind of why we're now, over the years, moved away from single syndrome type of testing to whole sort of panel testing. So not just focusing on 5 genes, but multiple genes that could sort of rule out more than just one type of syndrome that could explain the family history.
So it gives more information
Exactly.
to the provider and also to the patient to
Right.
better develop a plan of care.
Exactly. So, for example, if Kim had only done an analysis of BRCA1 and 2 and she came back negative, I would say, yeah, that's great. We reduced your risk dramatically. Can't necessarily give you that clear cut, and not to say that, and no genetic testing can do that, right? Because we don't understand genetics in that extent. I wish we did, but we
Right,
don't,
right.
right? So, but we can get as close as we can, right? Now, I tell my patients all the time, I can do whole genome sequencing if I wanted to. I can look at every gene I want in a person's genome. But most of those genes have no information to fall back on to
Right.
say, yes, there's a risk, this is what it is, and this is what we can do about it. And the last thing I would want to do for a patient who either has already had cancer diagnosis or has a family history that's scary, that's concerning, and each person interprets that differently. The last thing I want to do is give her a genetic test result and say, or him, a genetic test result and say, yeah, we found a genetic change. Can't tell you anything about it, right? I want to be able to say, yes, there's a genetic change, and here's what I know about it. Here's what we can do about it. Let's create a management plan personalized for you and your family. And that's the
Excellent.
goal. And so rather than doing whole genome sequencing or 60-some gene
Right.
panels,
Right.
in our facility, in my clinical practice, what I do is make sure that we choose an accurate test, a test that was validated. That's a big thing of accuracy, was it validated? Can I look at the studies that were done to say, yes, it's been done, it's accurate. Those that were tested got accurate. It was, confirmed by different type of tests, those kinds of things. That's number one. Number two, there's departments. Myriad Genetics has a department that's huge that all they do in and out is they look at variants, at changes in DNA and say, yes, this is what it means. This is what it doesn't mean. I don't know what it means. Let's do more research, right? So I want to make sure that my lab that I choose has the steps it takes and the things in place and the processes in place to make sure that the tests I'm sending or the results that I'm receiving are accurate, and that I feel comfortable providing a patient a result
Right.
that they can act on it and feel comfortable that that is actually the result that they're getting.
So if I were a patient going in with a strong family history, I would want to make sure the physician knows that I would like the most amount of information I can get from that testing to help me in my personal action plan, also for my family, correct?
So the second part is the most important thing. So we can give you more information, but you can't necessarily act on it, right? So yes, the most information that is understood today, right?
There you go.
So again, that's part of a genetic counselor's world of trying to make sure that a patient knows all their options and that they
Right.
know which option is best appropriate for them, not just because it's appropriate medically, but it's appropriate for themselves, right? So there are some patients who are going to say, well, I don't know if I want to know. I don't, let me go talk to my family.
Right.
So they'll go back, but they'll go with the information that I provided. I've educated them enough, hopefully, to say, this is your family history. This is why it's important. That's what I'm looking at, and this is what I'm concerned about. The only way for me to know whether it's really concerning is to look at your DNA. And if I can't look at it, I won't know. There's
Right.
still things we can do for you to figure out, is there somewhat of a baseline risk that I can act on? It's kind of the same idea of a high risk negative, but at the same at the same time, I won't know until I look at that DNA. Sometimes it's scary for patients. I think a lot of that fear goes away when you see somebody with that knowledge that can break it down and explain, what does that mean? What can we do about it? Why would you even want to know?
Right.
Why should I even consider it? Because we can prevent. And that's the goal.
So going back in time, this sort of testing just started in the late 90s, isn't that correct? And at that time, the test results took so long that it really wasn't even a part of the active treatment plan for someone who had a cancer diagnosis.
Right.
So how has that changed the timing? And if someone has a cancer diagnosis and then they have the genetic testing done, how has that changed now?
Yeah. So you're right. It's crazy to think that genetic testing has changed so much in that sense. But it's very quick now. We can do so many more genes very quickly. So it's today it's called next generation sequencing is what we call the technology. It's kind of like a chip that we have all these genes in one place and you get it in one type of test, right? Where, in the past, if you wanted to do that, you had to do every gene separately, right? So it will take forever to do.
So that had to do with the timing then.
And it would be an approach, right? So you would do, okay, the patient meets criteria for this type of testing. We would do that. If that's negative, then we'll rule out the next
then
species.
you keep
right?
going.
Right. Now you meet criteria, and that's the beauty of genetics, and that's the beauty of what I do every day is I can say, yes, you meet criteria for this, but I really need to rule out everything else that could also be in the family that could explain. But there's all these other breast cancer genes that I can test you for. But there's no criteria for the testing for those genes, but I can do the full panel testing because you meet criteria for one syndrome. Right. So going there and testing all these other genes that I really need to rule out because of this family history or personal history is amazing. And it really doesn't take longer. So the tests that we do, the lab actually quotes about 4 to 6 weeks to come back. I've actually never seen it in more than 3 weeks for 28 genes. It's insane. So getting that information, and they don't just give you a result. They give you it's amazing. They give you risk assessment. They give you management plans. They give you what guidelines say, what they did to test for it. What's the result? Is there what we call a VUS, a variance of uncertain significance, meaning a genetic change we've never seen before? Do we need to do more research for that? They give you basically a little booklet that's personalized for you. You, the patient, this is your family history. This is your personal risk factors. That's what it means for you. And so all of that in 3 weeks and insurance authorization, all that stuff all goes into that.
So 3 weeks, it could go into planning, especially for breast cancer patients is where I've seen it used in the past, whereas maybe somebody was going to have a lumpectomy.
Exactly.
But if the testing came back positive, they might opt.
Yeah. So I have plenty of patients that do come. I have referrals from breast surgeons and oncologists say, hey, this patient was just diagnosed. We call them surgical decision patients. And so I can put those patients on a rushed test, and that can come back in a week.
Wow.
Yeah. So the goal is to say, okay, if there is a rush test because we're waiting surgical decision, then we can rush that test and get it quicker so we can make that decision, especially if the surgery is scheduled already. Now, you might ask, why would we do that, right? So different management plans are different depending on what diagnosis you have and what family history you might have. So if a family or if a personal family or a personal history says, you've had a breast cancer, we really want to decide, are we doing a lumpectomy with maybe a little radiation, or are we doing, full mastectomy, double, unilateral, whichever that might be? And also, are we just worried about the breast, or do we have to remove ovaries? Do we have to do those kinds of things? So having that information without a genetic test that says, yes, you should get these done, it's not going to be done unless you want to pay for it out of pocket. So obviously you can do whatever you want with enough money, right? In this country, you can do whatever with money. So you can do it. But when it comes to predisposition, when it comes to management based on risk, we have to have that indication to say, yes, it's necessary.
Okay.
The idea is that every surgery has its own risk, right? We're talking sedation. Are we talking, what kind of surgery do we need to do? Also, the type of specific surgery you can do how are we removing the ovaries? How there's different types of specific surgeries for removal of specific organs, and there's guidelines for that, depending on whether or not you have a specific risk.
Okay.
Right. So, what type of surgery are you doing? What are we removing? Those kinds of things.
So that's for someone who already has a cancer diagnosis and maybe they're looking at a treatment plan. But for maybe a young person who has a strong history of colon cancer in their family, let's use that as an example, and then they come to you, what do you talk to them about, and then what's sort of the outcomes of those visits?
Yes. So, very good question. So, mainly we talk Lynch syndrome. So, Lynch syndrome, just like hereditary breast and ovarian cancer syndrome, is a hereditary predisposition to cancer. And what most people and most physicians don't know is that the prevalence of both of those syndromes is actually equal. It's about 1 in 500, 1 in 400, 1 in 500 in the general population for these syndromes to pop up. So that's the big thing. So that's why whenever we talk about family histories, we talk about both sides. Ovarian cancer, okay, do we have colon cancer? Do we have breast cancer? Do we have stomach cancer? Do we have those kinds of things? On the colon cancer end, the big thing with that Lynch syndrome is that there's about 13 different types of cancers associated with Lynch syndrome. The main types of cancers are colon, ovarian, we have endometrial or uterine cancer, we have gastric cancer. Those are the top 4 cancers that we're looking at. So if those are in the family, then we start, that suspicion comes up. When we talk about those things, there's other cancers that are associated with it. There's brain cancer, kidney, there's liver, those kinds of things are still there. So having those other family histories that may not be in the guidelines is still important. Testing for these genes, and there's 5 associated with Lynch syndrome. Testing for those genes and having a positive genetic change means you have Lynch syndrome. That basically means that you are at risk for all of those cancers, some higher risk than others. So for colon cancer, it's about, I want to say 82 or 84% risk for colon cancer. Uterine cancer, about 71% risk for cancer. But things like brain cancer is about 5-10% risk of brain cancer, and some of those things are less. So again, having the conversation that you have all these risks. Now, you may not do things like removal of your colon when it comes to that. Especially when there's not a lot of polyps going on in the family. So that's the other question that needs to be asked when it comes to family history, is that has anybody had colonoscopies in their lifetime, not one, in their lifetime that have had multiple, sometimes more than 10, 15, 20 polyps in their lifetime? That is also a risk factor as well. So having that information, knowing that you might be at risk for those, knowing that the family might be at risk for those things. Again, who's at risk? What are you at risk for? So talking about that sort of GI world of cancer.
And so, sometimes we think, again, I'm going to use Angelina Jolie as an example of, she went in, she had double mastectomy, then she had her ovaries removed. But for instance, talking to Tammy last week, she said, we don't often have to do those things. It may be closer monitoring. It could be diagnostic screening. It could be testing. I mean, there's sort of a whole range of actions that could happen. So what do you advise patients about, or or is it the test booklet that kind of talks about what are the possible things that would happen?
So genetic counselor's job is to kind of give you what's available for you. What's your options? Once, let's say, a patient was tested positive, what's available for you? It is going to be up to the patient and their provider, either their referral oncologist or PCP, general practitioners. Those are the individuals that are going to work specifically directly with that patient to create a specific management plan. My job is to, again, educate that patient about what's available for them in terms of guidelines, what guidelines, published medical guidelines indicate that's appropriate or that's necessary for them. And then they will then advocate for themselves of what they choose to do, why they want to do it, those kinds of things. So, for example, let's take HBOC, hereditary breast and ovarian cancer syndrome, BRCA 1 and 2. A patient who's positive for that, I talk about different things. So I always say to a patient that when it comes to the breast risk, you got options. We know so much about breast, and screening is so amazing when it comes to breast. getting better and better every day, that you have options. You can go the drastic route of, you know what, I don't want to have to worry about it. Let's go with the mastectomies. That's one option. It's going to be covered. Everything's fine.
Your
Then
risk goes way
way
down,
down,
if you
correct.
decide to have prophylactic bilateral
zero.
mastectomy. Never
Exact-
zero, but it goes way down.
Exactly. So we always talk about that, the fact that that's your best option when it comes to risk reduction, right? But some patients are not really ready to remove their breasts. It's one of those things that makes me feel like a woman. I don't want to do this. I'm not
Right.
ready for that. In fact, actually, about 50% of patients actually choose to do surgery, and the other 50% actually say, you know what, I'm not ready for this. Let's do screening. At which point we'll do 2 clinical breast exams a year. One would be at your annual exam. We do a mammogram once a year, and that starts early, around the age of 30.
Right.
And then you're also going to get an MRI, breast
Right.
MRI. So and a lot of my patients actually set it up with their patients or with their providers where they're seen every 3 months. So clinical breast exam at your annual, 3 months later mammogram, 3 months later another clinical breast
So
exam.
they're being seen all year long.
Exactly.
So
So
that
if
brings
something's
their
there-
anxiety level down too, because
Exactly.
you're being seen a lot.
Yeah.
Right?
So again, that kind of is worked with the provider. When it comes to ovarian cancer, however, that I always tell patients, I'm not really giving you an option, even though obviously I can't do that. It's up to the patient, right? But I explain saying there's just not great screening for ovarian cancer. You just can't find it early enough with what we have. So better than nothing. So if you're not really ready, or if a patient is in their 20s, I'm not going to take their ovaries right then
Right.
and there, because consideration of early menopause, that's the other thing that needs to be considered. So in terms of age, but again, having that removal of ovaries, and that is pretty much the only way
Right.
to remove or reduce that risk of ovarian cancer.
But screening, they can do transvaginal ultrasound. They can do some lab work, but it doesn't necessarily show that
lot of
it's
false-
ovarian
yeah.
cancer. It could show there's other things. So
Correct.
it would be sort of an informed plan that they would look
Yes,
at, and then maybe wait until they had their babies if they want to do that. And
So
go
planning
that
for
route.
pregnancies, those kinds
Right.
of things is like, okay, she's 25, not
Awesome.
ready to have kids. Okay, let's at least have that conversation of what that means. Actually, removing your ovaries actually also reduces your breast cancer risk by, I think, about 65% or at least 50%.
So changing gears a little bit, some of this information might be very scary for people. As a breast cancer survivor myself, an oncology nurse, the first time I sat in a lecture and heard about this, I was sort of consumed with guilt in a way that I might be passing this along to my children.
Yep.
And it was very tough initially. I had to sort of work through those emotions before I decided, this gives me some power over what has happened. So what sort of emotions do you see, and how do you help people through that?
It's a great question. So one of the big emotions that we always deal with in the genetic counseling world is exactly what you said. It's that guilt, right? A lot of it actually comes on the initial part of before even doing testing. Do I really want to know that I might have put my kids at risk, right?
Yeah.
Is that I'm already starting with that sort of guilt, shame sometimes. It's like, do I have that? What will people think? There's a lot of different things that go along on the pre-test consultation part.
So you see them and you talk to them for a long time.
Yes.
It's not like they come in and let's do
No.
this thing and
I always say to my patients, you coming to see me does not mean you're getting a test. We are
Okay.
going to talk about the test. Let's talk
Okay.
about what this means. So when I say, is a test appropriate for a patient, it's not just medically. In fact, most of it is not medically, because most patients who come and see me do meet criteria for testing. And so if a patient comes to me, most likely medically, we already hit that.
Okay.
It's done. So the most important piece is, how is that going to affect you? What does that mean to you? Why do you want to know? And 9 times out of 10, a patient wants to know because they have kids. Did I pass it on? If I
And
have
Kim
that
mentioned that
information,
too.
exactly.
Yeah.
So
Very
you said,
important. For me, it was to give my children a chance.
Exactly.
If I was
Yeah.
positive, then they had a chance to be proactive very young in their life. and maybe prevent cancer completely.
Yeah, exactly. And that's the goal, is to say, I have a genetic predisposition, possibly. I don't know if I've given it. It's that 50-50, right? So how do I know? I have
Right.
to test. But if I don't test, I'm not
you
giving,
don't know.
right? I'm not
Right.
necessarily giving them the opportunity.
Right.
Because the farther away removed from the individuals in the family who've had cancer, the less likely you are to meet criteria. Unless there's a known mutation in the family.
Right.
So there's different things that we look into when it comes to criteria, not just medical criteria, but also what does that mean to you and what are you going to do with the test, right?
Right.
If you're going to do the test just to do the test and not really do anything about it and, sit there, is it really appropriate for you? So we have these conversations.
Right.
Most of the time, the vast majority of the time, getting this I can tell you every single patient that walks in the door gets some sort of an aha moment. What? That's my risk? Or, oh, I can find out that I can prevent that? My kids can? Oh, really? So I have all these sort of emotions of fear, always initially a fear. I shouldn't say always, but most of the time I have that sort of, do I really want to know? Or what if?
Right.
Getting that information, revaluing it on the back end. There's always that relief of, okay, I can do something about it. I can be in control, right? Because most of the time people think cancer, I'm not in control.
Right.
So that's a big one. The other thing is anxiety, right? It's not just with that guilt, but also anxiety of, what if I do get cancer and I do all these screens and nothing works, right?
Right.
It's very rare. We know, if I know ahead of time before you get cancer, your chances are way, way better than if I'd not known, right?
Right.
Because
Right.
honestly, if I didn't test you and this family history means you meet criteria, you might be a ticking bomb out there and I don't know and I can't do anything about it
Right.
unless I look, right? So having that information really empowers people to say, yeah, I might feel guilty, but really, if I know, I would feel worse if I had not known and not
Right.
provided the opportunity for my children to make that decision for themselves, right? If I didn't give them that information, they won't be able to make a decision.
That's right.
Right.
So I like that word, empowerment. When I did the testing back in the year 2000, part of the reason that I did it is I thought, I do want to know for my children. I want to empower them, just like Kim said, for her children. Now, what I find interesting is we've come a long way. In the 1960s, we didn't know anything about that. A lot of times if people died, we said they died of liver cancer when they could have died of breast cancer that spread to the liver, or they died of bone cancer, which is very unusual. It could have been from breast cancer. So we've come a long way. But what research do you know that's going on now so that we can look toward even a more bright future with what's going on?
Yeah. So a lot of research goes towards, a lot of it is treatment, right? A lot has to do with making, chemotherapy a little bit more bearable, and how does that react? How do we reduce that sort of, how do we shrink that cancer? A lot of it has to do with treatment on the back end. So there's so many good things coming out in the future about how to treat those cancers, how to prevent cancer, chemo prevention. What drugs can we use to make sure that, even if you may or may not, even if you're at a familiar risk, can we provide you something that could reduce your risk even more so? Research about different types of treatment that would reduce risk more than others. Surgery, can we do other things? Research towards things like screening, right? Screening of ovarian cancer. How can we make ovarian cancer screening better so that we don't have to remove ovaries? Those kinds of things. So there's a lot of research. In terms of the genetics and testing aspect, a lot of the research focuses on the genes that are included.
Okay.
How big are the panels? Is bigger is actually better? Is it not? What can I tell a patient? Can I act on this? What do guidelines say? So a lot of those things are focused on next steps and what can we do next? What type of genes can we do? Should we test for those genes? Should we even offer that to a patient? What are we going to do about it if it is positive? So a lot of that has, and the technology, right? We want to be able to, if we are increasing the panel size, we want to not have to increase the time it takes, right? So there's a lot of that. So there's a lot of different research in many, many different aspects.
So as far as being aware of research out there, there's an excellent group called Facing Our Risk of Cancer Empowered. It's a nonprofit. They have a great website called facingourrisk.org. And I know that they're there for support of folks who have a genetic mutation that's been identified, people maybe that are concerned about it. They also put a lot of information about research that is out there, legislation, for instance. I know they do that. I found another website which I was very interested in. It was called kinfolk.org, and it was a way for people to really gather information about their family history, and it was a very informational site too, another nonprofit. And how would you suggest, do you have other ways that you would suggest that people get information? Like if they wanted to contact you, for instance, how would that happen?
Yeah, so those two resources are actually incredible. They're very patient-based. Even providers sometimes go there to kind of find information that and help themselves explain things to patients, right? So this is a great resource for information and events and fundraising, those kinds of things. One other amazing resource that I would say, especially if you are looking for genetic counseling in your area or the closest to you, because we are limited in the number of genetic counselors, unfortunately, is National Society of Genetic Counselors, so nsgc.org.
National Society of Genetic Counselors.
Yep. So so there's it's a great resource to find out information about genetic counselors, what we do, different fields, and then find a genetic counselor near you.
Okay.
So it's a great resource to go to find out.
And maybe if there wasn't one in your area, I know that Tammy said last week, 2 weeks ago, she said that Myriad, which is one of the testing companies, has genetic counselors on their staff, but you could also request from your physician, when you talk to them, I'd really like to see a genetic counselor in conjunction with my testing. So that's something your provider can help you with.
Absolutely. So your provider should be the number one people you go to, your individuals, your medical advocates to getting that information. And if there's something that you are really believe in and you really want to do and you really want to follow, you put your foot down and you advocate. You push and push until you get what you want. So there's different opinions out there. There's different providers that follow different types of or interpret different types of guidelines differently. So again, if there's something that you want, if there's something that you need and you really want to get done, push for it. They have the resources to find genetic counselors or whoever provider you want. They will be able to do that. And if they can't, other people can. Okay. So those are the first people you should go to, I would say.
Well, you have given us just a brain full of information today. And Kim, I really appreciate your perspective too. And Nira, you've given us a big lecture in a small amount of time. I'm sure people still have questions, but I so appreciate y'all being here today and sharing your knowledge and your stories with us.
Happy to be here.
Thank you. So this recording, if you're not watching it live, it will also be available next week on our website, which is Hope Abounds, or through Roku or also the Hope Abounds app. I wanted to tell you that in 2 weeks, we'll start a couple of webcasts, and that will be about the topic of lymphedema. Lymphedema can happen after, this is secondary lymphedema associated with cancer, so it can happen after surgery or treatment. And so we'll be focusing on that, interviewing some folks that have lymphedema and also some experts in the area. Thank you so much for your time, and we hope to see you in 2 weeks. Thank you.